and it has reduced density of both small and large nerve fibers. And also there is Wallerian degeneration of the nerves. There are sensory and motor deficits. They are also caused by direct neurotoxicity of acetaldehyde from ethanol and protein kinase C epsilon, which will lower the threshold of the nociceptive receptors. And that will be mainly described as patient feeling more sensory pain from a given sensation. How do you diagnose? You definitely take the history of the patient. You also do some vitamin deficiency reports, especially vitamin B. And EMG and CV studies will also show, and they will both be positive because motor and sensory fibers both are involved in alcoholic neuropathy. So it won't just be limited to NCV but also EMG. And as I think you all know that EMG will measure mainly the motor function, whereas NCV will measure mostly the sensory function. And there is seen like a reduced amplitude in sensory. Of course, stopping alcohol intake is number one thing that you want to consider, and providing the patient with sufficient vitamin deficiencies and giving them vitamin supplements. Even as required in the early treatments, the patient can receive parenteral vitamin B12 to get the nerves to regenerate again. And as I mentioned before, any nerve that is peripheral has a very high chance of regeneration if it is treated properly. For HIV, it also affects the distal or peripheral nerves in a symmetrical sensory manner. It is also related sometimes to the treatments with antiretroviral medications. And about 50% of patients who have AIDS, not HIV but AIDS, which means a higher level of HIV, and there is opportunity infections already in place. And 30 to 50% of these patients will have HIV neuropathy, and up to 70% will have it in advanced disease. And advanced disease is more than one system involvement due to secondary infections. So if infection due to lung infection, for example, those are the ones with advanced AIDS, and they have about 70% of HIV neuropathy, which has to be treated. And the infections themselves, like the CMV or herpes zoster, may also cause the neuropathy in this patient. Neuropathic pain in general, how do you diagnose them? So clinical presentation, of course, is number one thing. And as I had mentioned in the previous webinar, this difference between a nerve root and a nerve is quite evident when you examine the patient. So if someone has a radicular pain from L4 versus someone has a diabetic neuropathy in the foot, their presentation will be very different, because diabetic neuropathy will not involve these nerve roots at a higher level, above the knee, for example. And their sensation will be completely normal above the knee, and their presentation will be only below the knee. Whereas if the patient has a nerve root involvement of L5 or L4 or S1, you'll see the involvement in the entire distribution of the nerve, and of course they will have positive straight leg raising test or any other function, or they might even have weakness. Whereas diabetic neuropathy patient will probably not have weakness, they will just have pain. So taking the history, of course, is very important. How it started. Most of the neuropathic pain that is either polyneuropathy from etiological factors like metabolic factors or infection, they are more likely gradual, but they could be traumatic, and they might be all of a sudden. But the trauma itself can tell you if the pain is from because of neuropathic origin or not. So the same way, when we talk separately about complex regional pain syndrome or CRPS type 1 and 2. So type 2, as you know, is not one of the peripheral minor nerves. Looks like the sound is back again. So in the laboratory studies, what we need to look at is any metabolic causes, for example diabetes, and we can obtain an EMG and NCV study that will also further help in diagnosis of neuropathic pain. It will not tell you about the neuropathy, and then depending on the patient's character of the symptoms, you interpret that as neuropathic pain. So when we decide to treat these neuropathic pain syndromes, we can treat the cause and or the effect, or we can treat both. Sometimes it is not possible to treat the cause because, like I said in that example of the prostatectomy patient with scar tissue, the cause, which was the scar tissue around the nerve roots of S2 and S3, was not really treatable. So we had to treat the effect, which was the inflammation of the nerve roots, and putting the corticosteroids around there was more effective. But a lot of times you can treat both. For example, in acute phase of herpes zoster, we can treat the cause with antiviral medications, and also we can treat the effect, which is the pain, and we can treat that with initially with even epidural steroid injection, because there is a lot of inflammation at the dorsal root ganglion level, which is the primary cause for this virus to be regenerated or revitalized. And by reducing the inflammation at the DRG level, we can treat the inflammatory response of the nerve itself. And so most of the time you might be able to treat the cause and effect. Same thing with diabetic or alcoholic neuropathy, HIV neuropathy. You treat cause and the effect, treat both of them at the same time. Never focus only on the effect, because that will lead you to false senses and that the patient may have pain from something else, whereas actually the cause of their pain might be relatively untreated. Same thing happens with when people have smoker's limb, for example, the TAO, they will have burning pain similar to diabetic neuropathy. So if you don't advise the patient to stop smoking, they will continue to have this neuropathic pain despite all your treatments, and that might lead you to believe that your treatments are not working, or you might want to look for something else that might be a red herring, and it may not be the cause for the actual pain. So just to mention again, the cause that is the smoking should be treated along with the effect, which is the neuropathic pain. So when we start treating the cause, we remove the cause. For example, if the tumor is there, you can try to remove the tumor. If the scar tissue is there, you can try to remove the scar tissue, but not really the nerve itself. We can loosen up the scar tissue sometimes. For example, when the patients have radicular pain from post-laminectomy syndrome, that pain is not too much different than neuropathic pain. And that scar tissue can be loosened up with special catheters, such as the RAS catheter, and adhesiolysis procedure can be done, which is very effective if done in the right patient in the right way. And the tethering of the nerve roots is then loosened up, and the neuropathic pain would feel much better. You can correct the disease, like for example diabetes, alcoholism, HIV, like I mentioned, and sometimes correcting the disease itself might cause additional neuropathy. For example, HIV, antiretroviral drugs can cause neuropathy, or cancer medications, anti-cancer drugs can cause neuropathy, radiation can cause neuropathy as well. Our main purpose is to treat the pain, and also the secondary concern is to treat that dysfunction, because whenever there is pain in the periphery, in the limb, the patient will have a tendency to protect the limb and to protect it and not use it normally, and that could lead to more arthropathy, distal atrophy of the muscles, and loss of limb, as we see in advanced cases of CRPS, for example, or someone who has a cast after a fracture of the elbow, and they are in a cast for 6 months. You see, you can not only see their pain, but more of their dysfunction, because they have not used the extremity for some time. So when we treat the pain, as I mentioned multiple times before, we start treating them with either origin, transmission, interpretation, or all three of them, or any two of them. So when we treat the pain at the origin, it could be done with local infiltration, and that works only for short-term pain. For example, if it is traumatic, or it can also work long-term when we apply topical local anesthetic in the form of a patch, which is lidocaine patch. That can work for a long time. Clonidine can also be used, and the way it works is in periphery. It will work with peripheral vasodilatation, improving the blood flow. And the two things that can be achieved with that, number one, the blood flow improvement will also help regenerate the nerves faster. And number two, it will reduce the ischemic type of pain. And of course, the alpha-2 blocking property of clonidine will also help with interpretation and transmission of the pain at the central level. Then we can also look at depletion of the pain transmitter. For example, substance P depleter, which is clonidine, capsaicin. And capsaicin is the main ingredient of hot chili pepper. And so when it is applied initially, it will release the substance P, and that is what causes the burning pain. But when repeatedly applied, it will deplete the substance P, and finally the patient will have pain relief from the given origin of the pain. NSAIDs can also work by reducing the inflammation around the nerve, and neurolysis, of course, will treat the origin of the pain at the very initial stages of transmission of the pain, which is the very small peripheral nerves. And the neurolysis, if done on a very tiny end nerve, for example, the medial branch of the facet joint, they are not very likely to cause central pain syndrome in the form of deafferentation pain, which we see more often with trigeminal neurolysis, or any neurolysis that is done at the central level. For example, the chordotomy and rhizotomy can also be done, but only in terminal patients who are terminally ill with cancer. And in those cases, the deafferentation pain will take much longer to start, and by that time the patient will be most likely dead. So the neurolysis can be achieved in multiple different ways. Surgical neurolysis can be done, chemical neurolysis, thermal neurolysis, which we do with radio frequency, chemical neurolysis done with alcohol or phenol, injection used mainly for cancer nerve treatment, and especially for sympathetic nerves and sympathetic nervous system and plexuses for visceral pain. Surgical, I had experience with some patients who had surgical herniorrhaphy syndrome, where the iliohypogastric and ilioinguinal nerves are encased in the scar tissue, causing relieved by any of our blood medications, and we did not have the luxury of doing peripheral nerve stimulation at that time, and I'm talking about 93, 94 and 95. And so what we did for some of those patients was we opened up their abdomen under anesthesia, and then we cut the nerve, and we cauterized that end after we blocked the nerve initially. So we performed the nerve block, and when the patient had no pain, after that we opened the area, and we cut the nerve and buried it underneath the muscle, so it would not form a neuroma, which could lead to more pain. So, but that doesn't be applied anymore, because now we have better options in the form of radio frequency, even peripheral nerve stimulation. So when we treat the pain during its transmission, it could be the peripheral nerve, or it could be the central transmission at the level 2, which is the second order neurons from the spinal cord to thalamus, or the third order neurons from the thalamus onwards to the peripheral cortex. The nerve blocks will, of course, treat the transmission at the peripheral levels. Peripheral neuromodulation is when it is done outside the spine itself, so it can be along the nerve root or a nerve plexus. Fibers placed along the foramina, so they will come out along with the nerve root, and they will stimulate just the nerve root and the DRG as well. And the DRG stimulation is one of the newest form of neuromodulation treatments that is available, which is very effective and very specific for a given nerve fiber or nerve root. Central neuromodulation is basically neuromodulation at the level of third order neurons, which is beyond the thalamus, and it is also called thalamic neuromodulation, mostly done by neurosurgeons using a burr hole and fibers placed within the thalamus to stimulate that. It is also called brain stimulation or spinal stimulation. Neuroplasty, surgical neuroplasty can also be done when the nerve itself is released from the scar tissue. So plasty basically means repair. So if the nerve is encased in fibrous tissue from a scar tissue, that can be removed. But most of the time the scar tissue is regenerated and cause the same problems again. So most of the time surgical neuroplasty is not a very good option. And neuroablation, of course, will ablate the nerve that transmits the pain signal. Indian, which is more of a central nerve in that form. When we treat the pain at the level of okay, you have no audio, but I think everyone else has audio right now, so my mic is working okay. Does anyone else have an audio problem? No, looks like everyone else's audio is fine. So it should be the problem at your end. You might want to re-log in again. There might be some audio lag, but my microphone is working fine. I can see that. Okay, good. So when we treat the central levels, let me see. At the interpretation, we can treat the pain with pharmaceuticals. Okay, one more person having no audio. I think that is an isolated problem because my microphone is working fine. Yes. Okay, so we can treat with pharmaceuticals like tricyclic antidepressants, gabapentin, pregabalin, duloxetine. They are all centrally acting analgesic medications. Opiates or non-opiates will also work at the interpretation level centrally, and we can use biofeedback and behavioral management for central modification of interpretation of pain. And treating the dysfunction is also, of course, very, very important. Physical therapy is important, especially patient who is recovering from the pain. But you want to provide them with proper pain treatments before you send them for physical therapy, so that their pain is not increased afterwards. Because so without properly addressing their pain, it is not a good idea to address just the dysfunction. Behavioral management, of course, can lead to patients' well-being overall. Rehabilitation is important, vocational guidance is important, and that is how we treat the dysfunction. And social service, which is one of the important aspects of treating chronic pain, especially in US. There are several options available where the patient's pain can be treated using social service, for example, providing them with